All right. So, good afternoon, good evening, good day to everyone. My name is Wale Amayan, and I'm the Adolescent HIV focal person at the World Health Organization in Geneva. It is my absolute delight, actually, to welcome you to the first. This is our first TeleECHO webinar series for the year. Last year, quite the engagement with this group, covering so many topics and subjects, bringing best practices and case studies right to your doorstep. And we're going to be going in that fashion this year. It is why I'm just so delighted to be able to have you. I can see, we have close to 100 people already joining and more coming ready. Of course, we have the TeleECHO platform to support that learning, that engagement that we so cherished and which worked so well for us last year. So this time we're going to be focusing on a population that you all know so well: adolescent mothers, young mothers, the most vulnerable populations, safeguarding their future and giving priority to their needs. That will be the focus of this webinar session. Just before I start, I'll just go through a few housekeeping items. If I can go to the next slide. And before that, I can see a few people introducing themselves in the chat box. I think it's great if you could put your name, your country, or where you're joining from, and the organization that you represent. I think that would be great in the chat box so that we can know you and sort of have that sort of engagement with you. So just to start by saying, we know the drill now. We try to, as much as possible, cater to a wide audience. So this session, of course, is translated in Portuguese and in French. So if you need translation, please just click on the interpretation button and just go to the language that you prefer. On the next slide, it's also to, it's a technology world. We often have, these Zoom problems. So if you have any of such issues, please just put in the chat box Echo IT so that we can, hopefully help you to troubleshoot any of these Zoom problems. I know that, logging out and logging on again sometimes, does work to solving some of the Zoom problems. Yes, I can see people already putting in their names, organizations. So please keep doing that. It's just a huge joy to have this sort of community of practice. From Kenya to Zimbabwe, everyone joining in. It's brilliant. Our session is being recorded, so we will deem attendance as consent to be recorded. So thank you so much. And of course, we will be sharing this, the slides, the recording as well, so that people can have this in their libraries and get some of the lessons that they couldn't get during the session. So we'll be sending those, to those that have registered. During the session, you would have, probably comments and questions, suggestions. What we say is, we want you to, try as much as you can to make use of the chat box and the Q&A box. So for the general comments and suggestions that you want to share with everyone, we would advise that you put those in the chat box. If you have specific questions to the presenters or to the panelists, those should be put into the Q&A box. So you see the Q&A box right in the middle of your screen, where you can pose your questions to our fantastic presenters and panelists. A certificate of attendance. This is actually really popular. We get sent emails on how you can obtain a certificate of attendance from being part of this webinar. You can do that by filling out a short survey, which you will get when you click on the link that will be sent near the end of this webinar. So the survey link will be put in the chat box and you will be able to click on it to be able to access your certificate of attendance. On the next slide would be, really the objective. And we've really, at the beginning, I spoke about how we've formed this huge, massive community of practice, to share and learn. And that is the goal of this, the WHO TeleECHO sessions. We want to be able to, as a community, flag challenges, share solutions, trigger, learning, sharing, and technical assistance at global, regional, and country level. And we've been able to do a lot of those last year. So I'm just hoping, and we are relying on a lot of you, to continue to, come together to be able to do, to share this and, to flag these, this need for technical assistance. Next slide, please. This slide is just again to remind us of the journey that we've come together, as a community of practice. We have, moved from, what started as in-country technical working group meetings, and we've missed those so much. I remember, coming to the countries, the sort of one-on-one engagement that we had in 16 countries, was just brilliant. And we did a lot together as a community using those technical working group meetings. But of course, we have transitioned to the ECHO platform. Circumstances, of course, have forced that as well. But I think we're doing well. We're making the best of the virtual platforms that we have, to be able to share these global updates, exchange experiences, really great experiences that we've seen shared, but also, clinical management considerations. We're able to, using this platform, present case studies to be able to learn and to share. One change that we have is that we're going to be having these webinars now bi-monthly. So every other month we'll have a webinar that is focused on a particular topic as chosen by you. You will recall that in December there was a survey where you gave us your thoughts, and we have all of those analyzed, and we will be sharing those with you. So those webinars will be coming the first Tuesday between 1 to 3, same time, 1 to 3 Geneva time. Next slide. And we have an agenda that allows us to to make presentations, but also to discuss. Shortly, I'll be handing over to the chair of this webinar, Maxi Jaconia from Her Voice Fund, where she is the coordinator for on this fund for Y+ Global. We'll have a video on young mothers as well, which you can look forward to. We'll set the scene by just making a short presentation on a technical brief that we've co-developed, WHO and UNICEF, on safeguarding the health and future of adolescent mothers, young mothers living with HIV. We'll have a main key presentation by Ilona Tosca, who's the Chief Research Officer at the University of Cape Town, South Africa. After which we will go into panel discussion. We have a rich panel, as you can see on the screen, who we can engage, and you can also post your questions as well, to them. We'll have a poll as well. After which we'll have Laurie Gillade from UNICEF SRO, who will give us closing remarks and round us off. So that's where I stop, as I hand over to Maxi, the chair, to take us on this fascinating, enjoyable experience for the webinar. Over to you, Maxi.
Thank you, Wale. Can you hear me?
Loud and clear.
Great, great. Thank you so much, everyone, for this wonderful time. I think I can say happy belated New Year, right? Because we haven't engaged, we haven't seen each other since last year. I am particularly excited because, you know what, I'm a young mother and this is the start of the year, and this session really kick us, through the year and really align with our projects, with our implementation, and how we can then really make sure that young mothers, in all their diversity, really, receive the services that they need, as well as, meet their particular needs at the end of the day. So really, I'm really excited. The session really speaks close to my heart because as a young mother, I know that we go through many challenges, especially now considering that we are in COVID-19. Access to actual services that we need is very difficult. We can talk of treatment, we can talk of other service needs, especially on sexual and reproductive health and rights. It's becoming even more difficult for us to access them. Largely to different challenges with COVID-19, and I'm particularly excited about this session because it's a kind of a collaboration, engagement, discussions that really brings out different strategies, different ways, different movements that we can build in order for us to then provide the quality, the accessible, affordable services, as well as technical assistance that we can to young mothers living with HIV in all their diversity. So thank you so much for joining us, and I'm really looking forward to this exciting time. To further explain in terms of young mothers living with HIV challenges, as well as in times and as well as impact to COVID-19. Really, I'm going to introduce a video on young mothers living with HIV that was done by our partner coalition of children affected by HIV. Then we can hear from them. Over to you.
Everyone was focusing on his or her own family. Maybe they had support from relatives, but relatives couldn't make it because they were also on their own. They had to support themselves. Even we faced problems of going to the hospital to get medicine. We had no transport. Transport means were very difficult unless you have maybe an identity card, or you have someone to take care of you, or even an organization. These young mothers were breastfeeding, so it was very difficult for them to breastfeed when they are hungry. Of course, the immunity is not good when you breastfeed, yet you're hungry as well. The baby doesn't eat well, doesn't get enough help. So we accepted help from different organizations as well. Like UNIPA helped us, and they used to provide food. They went to different facilities. They also got means on how to approach different individuals to supply the medicine. There was also a positive side because we had time for our babies. We had full time for our babies and our families. We found it easy to know what's hindering the children, what's disturbing them. You get enough time with your baby and you say that this is it, this is how my baby behaves, this is how he acts, or anything else. We found ourselves that we can do different activities such as knitting, maybe making tea pads, very many this, and for the opportunity, they are now selling their products and they are getting money to support their families and their babies. We had peer support from peers because to make our bodies healthy, or let me call it mental health, because if you're alone, of course, you're going to think negatively, but when you're with your peers, you have to think positively. So you get that happiness. You don't be in isolation. If we get support from different social media platforms, from like abstract from different organizations, and we learn from home. If we call our peers and we talk to them, mentoring them, that change can help us. We also do mental health, and we also teach the use of contraceptive to prevent more early pregnancies and to how to care for the babies. We need more support as young mothers, maybe the government, maybe other people from different organizations, maybe also ministers.
First thing is medication, because some of the mothers, they use transportation to go fetch their medication. The second thing that was made them become defaulters, also even they have a medication, they eat food. There was no food in the houses because they're not able to generate income. Some of them young mothers, they become homeless because the landlord didn't allow them because they didn't pay. They're not able really to pay their rent. They need to be empowered to take their own power, their own agency. For me, for a way forward, we need to create a safe space for young mothers to talk about themselves so that they can own their bodies. They can own their decisions. They can own their experiences. They can even own their stories to share. Secondly, they need support. Whatever funding coming, so that they can able to grow and get empowered and support not only a mother, a young mother, support both young mother and the child, plus including there is young fathers who are very positive, but they are very limited because of they are so vulnerable, even them. But also get them understand about HIV because they don't understand. It's very important that every family should recognize and put the invest to the programs of the young and youth. So we need to bring that to our youth so that we can have good leaders for the future.
Wow, 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 wow. I was getting goosebumps all over my body when I was listening to these different stories with different perspective. And what I love about is lived experiences of young mothers. So they share with us exactly what has been happening in their lives, in their own context, as well as considering that we are living in the times of COVID-19, how hard it is for them to then access services. And we know that these are different intersections that we have, that young mothers are also facing. They mentioned the issue of not having transport fares actually to go to the facility to collect their medication. They don't have food while they are also breastfeeding. They are living with HIV. They're also on medication, and they don't have other means to have an income in their lives as well. But what I love about young mothers, what I love about them is that they are the experts. They know exactly what we should bring on the table, what should be, discussed by implementers, governments, that are providing services. They've shared with us some of these different strategies, some of this support that they need. They need safe space to speak about their issues as young mothers, be independent, being, resilient with themselves, owning their space. I love that part because, me myself, I'm a champion of adolescent girls and young women in all their diversity, including young mothers. And I love that power, for them to make that decision. And I hope as we are also discussing these kind of, initiatives, implementations, let's also make sure that we have that, opportunity to empower them so that they can own programs, they can own everything that concerns their health and their lives at the end of the day. And one last aspect that I loved is that they called for all from implementers, community-based organizations, government, donors, to come together and have a collaboration, to work together, so that we combat each and every challenge that young mothers are facing in all their diversity at the end of the day. So as we are progressing with this conversation, I think we also start to hear some of these conversations coming up in terms of how can the strategic partnerships then help in terms of meeting the needs of young mothers in their diversity at the end of the day. Without wasting much of the time, I would like to give it back to Wale, who's going to then take us through the technical brief that they developed with different partners all together, who speaks to that program of young mothers safeguarding the future. I love that part. We are talking about the future. How do we then safeguarding their lives, their together?
Yeah, thank you so much, Maxi. And I couldn't agree with you more. What a spellbinding video. That sort of reminds us how important it is for people to be at the center of their own services, to be at the center of their destinies, to put what they need, the way they need it, and being able to articulate it and present that in their own way, I think is really, really key. So thanks for that summary, Maxi. So what I'm going to do actually is just a bit of context, a bit of background before we have the main presentation by Ilona. And one of the things I just wanted to share as a background is the technical brief that Maxi mentioned. That has been the platform through which we are actually having this webinar. The technical brief on adolescent mothers improving their outcomes was a really joint, great partnership and collaboration with UNICEF SRO to sort of bring forth some strategic actions. What should countries, be focusing on as we begin to continue to push this really important work on having adolescent mothers and young mothers at the center of programs. And before I do that, maybe just a bit of, on the next slide, just something before I go into those strategic actions is, a call for all of us, as a community, to begin to look at how we can, reject absolutely the unacceptable barriers. I call it, the barrier triad for inequitable access to care, especially by young mothers. Now it seems, and this is what we're beginning to see, that being young, living with HIV, but also being a young mother as well, is a sort of is a spore to a lot of things. One of it is, of course, the stigma, the discrimination, all of those structural barriers that we know are unacceptable, and that we know that we need absolutely to begin to call out and to work against if we're going to reach where we need to be. Of course, we know that as a result of these structural barriers, the environmental barriers like stigma and so on, there's beginning to to show a trend as well of poorer HIV outcomes. Some of the most important things that we know are key to to being on treatment, including adherence, retention in care, viral suppression. When we have those barriers and dimensions of access being tampered with, then invariably they lead to those poorer HIV outcomes. Of course, we need to look at this HIV services and access. We need to look at it as well from a rights-based issue. It is a right. So when Maxi was highlighting the video and we saw young mothers speaking themselves, it's not something that we're handing over to them. It is their right, to be able to have agency. It is their right, to speak for themselves. It is their right to have equal access, to services. And we're seeing that, the sort of inequality that drive the world that we live in today. COVID, of course, has really shown that we must begin to look at it as a rights-based issue and reject and speak up against, these inequalities and really abuse, really, of human rights. And then finally, of course, is the the COVID-19 pandemic that has affected us in, ways that we never could have imagined, when it started. Some people talk about COVID-19 being a leveler, but actually what COVID-19 and the pandemic has done is actually exposed all of these inequalities, So those that were, already sort of down the ladder with access, it sort of pushed them even further down. A lot of us have been exposed in terms of, how, some of the basic amenities, some of the basic things that we need in life to be able to, move from place to place, access treatment. All of those, got exposed and sort of pushed down the ladder during the pandemic. So it's just to provide that context and to say that as a group, as a community, as a global agency as well, we need to begin to reject all of these barriers that continue to hamper equitable access, particularly for young mothers. Next slide. Thanks. And a lot of that is also on having that sort of positive, powerful advocacy. We need to be able to build, our work together. So what Global Y+, what Max is doing, what UNICEF are doing, what WHO is doing, we can't afford to have those fragmented. We need to build on, what we have. In 2019, and that's the document you see to the right, WHO and SICABA, another organization, that really takes, young mothers, front and center, collaborated on this learning session where, evidence on scale and nature of the needs of adolescent mothers, the changes that need to be made at multiple levels, government, donor levels, policymakers, and society. That sort of came out. And that main point is that we must continue to complement, what we all do. We've seen certainly, with the technical brief that I'm going to present soon, that sort of collaboration, of course, by WHO and UNICEF. I think we have to begin to be in a place where our work is aligned and complementary towards getting to where we need to get to. Next slide. This is where, that now comes up, the strategic actions that are in the technical brief. I'd just like to point out that, for programs, for countries, please go to the websites, go to WHO and UNICEF websites where you find this technical brief, and we can see very clearly those 7 key actions that we need to sort of, program with. We need to mainstream in order to improve the outcomes that we so desire. The first is integration. So integrating adolescent-friendly health services is becoming a no-brainer, really. We know the value of integration and making sure that services are differentiated and fit into how people want to receive them. And I think we'll hear more about this in the panel discussion. Certainly strengthening, PMTCT services. I was in a discussion recently where people said PMTCT services are adult oriented, and they sort of, it seems like our PMTCT services do not really have that nuance to be able to cater to, to young mothers. And that's what we need to do. We don't need to, destroy and then build up. No, we just need to look at what we have and make those work and be responsive to young mothers. Number 3 is on protecting. Like we know, there's so many, levers for change, other things that we need that sort of become catalysts to change. One of which is education, and we must be able to protect that right, to education, to make sure that, young mothers, pregnant adolescents are not stigmatized and they are able to remain in school and get the education that they need. Of course, engaging, which is the 4th action, engaging the sexual partners. A lot of the time, and we've seen this, the men and adolescent boys, sometimes they sort of fall off the radar. But we know now that it's really important that, as we, definitely the burden, especially of new infections, are amongst adolescent girls and young women, but definitely without engaging sexual partners, men and so on, we would hardly get to, where we need to be. Number 5 is on establishing and reinforcing, those networks. We know how important, how key networks are for young people. So those family and social networks, need to be reinforced. And then number 6 is on, the referrals, providing the opportunity, for mental health, for sexual reproductive health through referrals. And then finally, on addressing the legal, social, economic barriers, age of consent, and so on. Those are really key to get into where we need to be. I think I have one more slide, and that is just to point you out to the technical brief. I've included the WHO and the UNICEF link, so please go to the chat box and make use of it, disseminate it, and let's get to where we would like to get to. As I hand over to Maxi.
Thank you so much. I really appreciate you taking us through different, challenges that young mothers are also facing, but also to went further to then highlight, what we need to do as a collective. You highlighted about one point in terms of, powerful advocacy. What can we do with what we currently are doing as organizations, as community-based organizations, as donors, as implementers? How can we then come together as a collective and be able to channel that energy that we already have and address some of these key aspects of young mothers in their diversity? Then we move on to different 7 key strategies, where you mentioned that we need to then kind of look at these different strategies and be able to align our work around those strategies and be able to collectively and holistically address these issues that young mothers are really facing. So really, thank you so much for that. And Wale, just a note to you, next time, you should bring me some presents, so that I give people some presents, let's, for example, if they can name the 7 key strategies like integrate, strengthen, establish, I think I should get a present. What do you think? I'm excited. So next time, please, I do need a present to give people online. So thank you so much for that. So I'll move on to the next presenter, who's my colleague, who's Elona, Chief Research Officer at University of Cape Town, who's going to take us through the, a research that they did on service provision for young mothers as well. The practical part of it, we need to understand more. We need to know what can we do more in terms of meeting the needs of young mothers. Over to you, Elona.
Thank you so much, Maxi, and thank you, Wale, for setting the scene and presenting the strategies. We've worked very hard with colleagues who are on this call, and many of you at the country level, to try and bring together data that helps us understand and give a bit more meaning and stories to these strategies based on how and what we know on the lives of adolescent mothers living with HIV and their children. And I'm presenting data today from primarily 2 studies based in South Africa, but they've really been enriched from discussions and conversations and learnings with colleagues in many countries, and especially colleagues from UNICEF and WHO, and many of Maxi's ambassadors that she supports and mentors. So for many of us, adolescent motherhood and HIV, we don't really think of them as happening at the same time or as being really important because, well, many of us are over 18, but in the lives of young people in the continent, especially given the demographic boom that we're experiencing, even a low rate of pregnancy can translate in millions of adolescent mothers. And coupled with rates of HIV infection, this can really mean that there's a large cohort of young people to support. So we expect there to be about 435 million adolescents in the continent by 2050. And there's other parts of the world with Generation Z and Alpha, are also going to be nearly 500 million in the next few decades. And this growth in population is happening in the face of persisting rates of HIV infection. So even if they stay the same, a higher number of young people just means more young people to support throughout this learning their HIV status, learning about and becoming mothers and their relationships. Evidence from the area tells us, and this is looking at studies across time, you can see that the top left, there's a table that summarizes studies from 2003 to 2018, shows that there's actually the prevalence of adolescent pregnancy has changed over time, but it can vary by groups and by region, but it remains quite high. And what's more interesting and what's also more important for us to think about is that adolescent, by becoming a mother or a parent early in life, this means that there is a higher likelihood of a second child and other pregnancies happening quite early. So a recent review that my colleague Dr. Banergun has updated at the University of Cape Town found that across studies, we're looking at about 1 in 4 adolescents and young people living with HIV that have multiple pregnancies, and are becoming parents to multiple children, not only one. The good news is that the numbers of births to women living with HIV have actually gone down over time. And of course, we want young women and all women living with HIV and all people living with HIV to have full sexual and reproductive lives and experiences and become parents when and how they choose to become parents. But knowing the different experiences and how unplanned pregnancies are, we really want to keep track of these rates. And the good news is that the rates of pregnancy have gone down, and even more so, you can see the line in red amongst young women living with HIV. However, keeping in mind the large cohort of young people living in the continent and globally, even a reduction in percentage can mean that there's a lot of young people and young mothers to support. What do we know from our research about pregnancy, motherhood, and service access amongst adolescent mothers living with HIV? This study followed about 1,050 adolescent mothers and 1,200 of their children, with a smaller group of a few hundred of them already living with HIV when they had their first child. And what we have found is that nearly 1 in 5 of them have 2 or more children. And when we ask them if their pregnancies were planned or intended, really 99% of them said that they were not looking to become pregnant and mothers. It doesn't mean that their children are not wanted. And Maxi, your energy and your passion for motherhood is obvious. And the video that we heard from the coalition, I mean, they all want to be amazing mothers and they really love their children, but they were not, the timing of this pregnancy and what led to motherhood was not something that they chose. About a quarter accessed the full antenatal care service package. We see that about 1/3 knew their status before pregnancy, but 6% ended up never starting antiretroviral therapy, even though they're living with HIV, and about a third say that they were taking ART before they were pregnant. And there is a bit of a discrepancy between those who knew their status before pregnancy and those who had started ART, and because there is a smaller group of those who were infected or acquired HIV since birth, who may have been taking ART but did not know that they were HIV positive. They had not yet been disclosed to. This is particularly true of very young mothers. When we look at information on their children, we see that, not surprisingly, a large proportion of them are really young. But this is quite important to think about when we're thinking about 1 in 5 of them having 2 or more children and becoming pregnant again. 3/4 of their children had been tested before 2 years old, not all of them following the recommended timing of testing, which would help also linkages to prevention and care. And 5% of them reported that they had a child living with HIV. Now, 5% is low, but we're aiming for even lower. And in South Africa, where this data is from, the rates of children acquiring HIV for overall, for all mothers, is actually at about 1.6, if I'm not mistaken. And this is about 3 times as high. When we're thinking, sorry, this bar at the top, I hope it's not bothering all of you. So what can we do to actually complement? And this links to the second strategy the first and the second strategy that Wale mentioned earlier. Well, this is not just about becoming a mother and giving birth, and the story does not end there. What about contraception and condom use? So both in terms of managing and timing future pregnancies and childbearing, but also in ensuring safer sexual relationships with their partners. These are, to the left, rates of hormonal contraception, to the right, rates of condom use. So bear with me as I walk you through these graphs, because we were quite surprised by some of this information. The line in red is all mothers. So the good news on the left is that adolescent mothers, all of them, are reporting higher rates of hormonal contraception than their adolescent girls and young women who have not yet had children. But the rates are still quite low. Even though they're actually much higher, they're still at under 2/3. When we look on the right, we see a switch. Adolescent mothers have much lower rates of using condoms, and these rates are equally low amongst mothers living with HIV and those who are not living with HIV, and they're at about just under 1 in 3 of them. I haven't shown it here, but when we actually looked at those who were dually protected, so both were using barrier and non-barrier contraception, these obviously become even lower rates. And these rates are also confirmed by a systematic review that I mentioned earlier, where we see rates of using any method ever in a lifetime use ranging from 1/3 to 3/4, but current rates of modern contraception use were in a range of 12.5 to 66%, depending a little bit on also the sample age. So when primarily 18+ were included, it was higher rates. So what can we do to make some of the services better? And this speaks a little bit to ideas. Many of us are thinking of a lot of different ways that we could apply the strategies. I saw some of the comments saying, I'm going to think about how I can bring this into our work. Well, we know what young people have told us over and over again what they would like to see when they come in facilities. And what we did together with some colleagues here is we thought, well, there's quite a few features of experiences of clinic services that we've asked young people to share with us. Are the services confidential? Do they feel safe getting to the clinic? Can they get to the facility without big economic barriers? And are they treated with respect? So when they're spoken to, do they feel that they're seen as humans? And what we tested about 11 of these. And these are the circles in black in the middle. And we saw that testing 11 different types of experiences of young people, we found 2 were the ones that were most significantly associated, not just with one outcome in this, say adherence to antiretroviral therapy, but actually all 4 of these outcomes. And what we're trying to think about is not just the one thing that you could do to change one outcome. A lot of our thinking is often, I need to get everyone on treatment. Let me see the one thing that I can do for that. But if we could think together and ask our data based on what our young people had told us, what could make a difference across multiple HIV-related outcomes? The good news is that the things that we need to do for adolescent mothers living with HIV on the left, and the things for adolescent girls who are not yet mothers, but living with HIV, were not different. So of course, we need to deliver the services in a way that is life and age stage appropriate. So we should think about what mothers need differently. But as long as we can get them to the facility in a way that feels safe and without economic barriers, the accessible clinics, and we can treat them with respect, so in a way that they do not feel shouted at, that's really made a difference, not just in one outcome, adherence to ART, but in reducing missed clinic appointments, in reducing treatment interruptions of up to a month, and in TB symptomology. One of the other things that Wale mentioned that our data has been quite powerful in really reminding us is that it takes two to make a baby. And because young mothers living with HIV are having their babies earlier, this also happens at the same time as exploring and potentially changing relationships with their male partners. So what we found is that even though they had already become parents, 2/3 of the adolescent girls and young women in our sample wanted 2 or more children. We need to support them to safely conceive and bring young people into the world. And we also need to think that this means that they're going to regularly come to health services. And how do we ensure that there's transition and smooth return to services and integration across different types of services that they need? About 1/3 of them had sex in the last year with a casual partner and with an older partner. And even though they're at an age where they could disclose and had known their status, 1/4 did not know their partner's HIV status. And the most worrying of these elements, there are positive elements and stories of partners that are supporting, but 1 in 2, just under 1 in 2 of them reported sexual or relationship and intimate violence. And this is not, this is happening in the context of high rates of first sexual violence encounters before 18, as you can see in the graph at the bottom from the Violence Against Children surveys across multiple countries in the region. We then try to understand how young mothers are feeling beyond their HIV and sexual and reproductive health needs, because when we talk to them, they want to be a good mother, they want to have a fulfilling life, but they're also struggling with being a mother. Maxi and I often share stories of sleep deprivation and who's looking after your child. And we sometimes forget that these are needs that also young mothers have. But this also can happen alongside mental health issues. So these are rates of common mental health disorders. And we're looking at 4 subgroups by motherhood and HIV status. And even though when one controls for age and other factors, the HIV status is not a predicting factor, what's struck our team is that just in terms of proportions, young mothers living with HIV may need additional and extra mental health support because they are the highest rate of any common mental health disorders in this state. And this was at times compounded by what one of our colleagues in her research with young mothers in Mpumalanga in South Africa called blankets of shame. These experiences of visible and invisible stigma. Living with HIV may bring young people living with HIV may experience several types of stigma that we all have may have talked to them about. But then there's also the stigma of becoming a mother, of the baby bump, and how young women felt that they had to hide and withdraw from their communities and spaces to protect themselves and the baby. Though it was very powerful that even though they had withdrawing themselves from and stayed at home to protect themselves and the baby, as you'll see the quote at the top, the young mother was very, really wanted to say that they were actually leaving their home to go to the clinic because they really wanted to protect themselves and their child. We have now been talking to these young mothers twice, and in the quantitative survey, what we did notice, and we're still trying to figure out what has happened, is that during COVID and after COVID, so data from 2020 and 2021, the rates of stigma that the young mothers shared with us were much higher. So the bars in blue are two times or more higher than the rates of stigma that they reported earlier. We're still trying to figure out why that is, but we know that that's a really significant barrier to service access. And it's something that we really need to really look deeply in our service provision and our support provision for them. And then we need to think about how young mothers fit in the overall and how we can support them in reducing and interrupting the cycle of HIV transmission. We looked at and there's a lot of malignment that can happen in thinking of, oh, those young people are going around and exposing others to the virus. But actually, a lot protecting their children and their partners is a really strong motivation for many of the young people in our research. And when we look at what is driving this overlap of sexual risk-taking and non-adherence, so viral viremia, is really being in very difficult relationships. So one cannot negotiate safe sex and taking ARVs, being in a house that doesn't have enough food, reporting quite high levels of substance use and recent HIV acquisition. And if we're thinking about how we can integrate some of these in service provision, the idea of, and this is particularly in both strategies 6 and 7, where we should think about how do we ask about difficult things that are happening at home? How do we try to actually link not just to the HIV and health service that we are meant to provide, but also address the other issues that are also worrying and really preoccupying young parents and young mothers. And then how do we do this with respect and taking into account how there are huge dreams and aspirations? We have mothers. This is a young mother on the left here drawing her school. She wants to be an architect when she wants to be an architect when she grows up, I'm going to say, quote unquote. And there's another quote from a mother about building a school and dreaming about how she can build a better future for their children. And this is where linking and thinking about cross-sectoral collaborations and ensuring that mothers have access to platforms such as education is very key. In the South African study, 3/4 of the mothers stayed in school during some part of their pregnancy, which is actually good. But those who were at risk of dropping out were already a grade delay at the start, which is also linked to higher rates of unintended pregnancies in this age group, came from poorer households, and had limited communication with their caregiver about sexual and reproductive health issues. The good news is that 70% went back to school after giving birth, but that's 30% that could not go. That's about 1 in 3. They were the ones who dropped out of school early during their pregnancy and who had no access to formal or informal childcare. So we've been thinking about what we can do, and one of the obvious ones from the slides so far is what would be the impact of food security? And we see that food security would, this is amongst adolescent mothers in our study, would reduce transactional sex, age-disparate sex, unprotected sex, improve school enrollment, and reduce substance use and sex on substances. And then the more obvious one, perhaps, but it's really helpful to look at the data, is what is the impact of childcare? Obviously, it improves enrollment. You're more free time to go to school by 20. Parenting children is supportive when they need us and stimulate them to grow into the amazing humans that we all know they can be. And finally, this is my last slide. How do we put this all together? And there's no magic formula. We all have to think what works for young mothers in our setting and young mothers living with HIV specifically. But it's also important to embrace and understand that this will change over the life course. And what we've been thinking a lot about providing material support in the form of food security and support to return to school and childcare. And then some of the mental health and the peer-based models, but also what the young mother may need or the young woman may need to transition to become gainfully employed or to have means of livelihoods, as we heard in the video. Thank you all for listening, and I hope if you have any question or comments, please feel free to email me and I'll look out for them in the chat.
Thanks, Ilona. And beyond the emails, I'm also hoping that your presentation, you probably give us the permission to share your slides as well. I'm seeing a lot of requests for it. So just because we are on time, there is just one thing I would like to hopefully engage you on, if you don't mind, before I hand it over to Maxi. I think it was quite striking when you spoke about the blanket, how and it's a really stark way to put it, and that's what it is really. My thought is that the environment that nurtures those blankets of shame might not necessarily discriminate between, or maybe it does, an adolescent or a young mother living with HIV compared to those not living with HIV, older. I just wanted to get your thoughts about whether there are some unique considerations and needs that sets apart adolescents and young mothers living with HIV compared to others.
It's such a good question. Max, you also feel free to jump in if there's from experiences and working with the Y+ and colleagues. There's a lot happening in a young woman's life, and especially throughout pregnancy and finding that out and coming to terms with it, and the visibility of the bump in the motherhood. And there are, that's a very visible kind of stigma, or it's a very visible way. It kind of goes back to even the label from the original Greek, I guess, of stigma. It's people can immediately see and respond. And there's a lot of it's not just about the young mother, it's also about the family that allowed this to happen. I'm using quote unquote. So there's a lot about the mother or the caregiver of the young mother and what they have to kind of how they're carrying some of the responsibility about what has happened. And then layered with and quite often in this age group, it happens at the same time, learning about one's HIV status and having to navigate kind of that what you thought about HIV before and the community level stigma and the exposures you may have had to HIV related stigma. Maybe you had a parent who passed away from HIV. So there was already stigma as we call stigma by association, and the process of navigating, learning your status while learning about becoming a mother and even physically going through childbirth and the adjustments to ART. There is definitely, I'd say, what we need to be extra careful. Instead of having to deal with one thing, you have to deal with two, even just purely in terms of one's energies. And even the most resilient people, I think of resilience a bit kind of like layers. You have used up a layer already to deal with one issue. Now you have another layer. And if these happen in the context of violence or hunger, then it becomes, so it's the stigma, and it happens then as well alongside all the other factors that may have contributed to both the HIV exposure and acquisition and the early unplanned motherhood. So I do think that there are some special considerations. And perhaps one last thought that we don't have a perfect answer for is I do think that we should very carefully support young women to disclose, as you saw earlier, and to think about disclosure, both in asking their partners about their status and the partner, but also about thinking about how they can, set up a relationship so that they can take their medication and use condoms if, for example, they are worried about transmission. And I think we don't have the full answer to that yet, because those are very difficult conversations for everyone to have, let alone say a 17 or a 19-year-old. I mean, we can all try to think back as to when we were that age and what we felt comfortable doing. So just to just be empathic and think of everything that's going on. And it's hard when one has 3 minutes per person to support through, care in a busy clinic, but sometimes just a gentle reminder, just that there's a lot happening. Thank you.
Really, really, really fascinating. Thanks a lot, Ilona. And there's some questions for you as well, in the chat, well, in the Q&A. If you could just help to respond to those. So I hand back over to Maxi. Thanks, Ilona.
Thank you so much, and thank you so much, Ilona, for such a rich presentation where you really unpacked, what young mothers do face, what they go through, and what different strategies we can then, start to think of how can we then address some of these key issues that you highlighted. And one point that I got is that it's not about enrolling young mothers, these adolescent girls and young women on that, then we need to go beyond. We need to look at other aspects. Are they comfortable enough, to engage at self-delivery? What kind of other, mechanisms can we support them in terms of addressing mental health, in terms of addressing stigma that they are facing as well? So really, really thank you so much for that. And I think that this presentation then brings us to this wonderful panel discussion that we want to have. And I think some of those questions that we do have, some of those key, answers will be coming from those panel discussions as well, from these different guys that we have, different experts, community, leaders, all together. And I'm particularly excited about this. So I'll hand it over to Wale so that you can take us through the presentation and the panelist discussion as well.
Yeah,
thank you,
Maxi. And just to agree with you as well that it sort of feeds into each other. So Eleona's presentation, evidence, research, and then some of the questions that were coming out in the chat box. I think there is a lot that we can speak about in the panel discussion to be able to sort of nuance and digest some of those considerations. So I have, the absolute pleasure, ladies and gentlemen, to moderate this panel. You would see that we have, Oti. Oti, we all know Oti. She's been a champion, really. Never says no. When we ask Oti, let's get on this wagon for adolescent mothers, for PMTCT, she's right on it. So Oti, of course, is the PMTCT lead at KwaZulu-Natal Department of Health in South Africa, and I'm just delighted to have her. Augustina Delaney. So Augustina is with the Maternal and Child Health Branch of the Division of Global HIV and Tuberculosis, CDC, in the US. A huge pleasure as well to have Peggy Kuchocha, who is the coordinator of the Young Mentor Mother, that program that we all know with another really well-known person, Immaculate Mutisia, who is the Pediatric and Adolescent lead with CCD. And then finally, on this panel to help us discuss and talk about some of these issues is Cindy Amaiza, one of my favorite people on earth. I think she's become that. So she's the coordinator, but she also doubles as the the young person advisor to the WHO Adolescent Service Delivery Working Group. So it is such a pleasure to have all of you. I hope you have your videos on, and we can start this conversation. And I'm going to start, with some of the gaps and some of the gaps and challenges that we have. Some of those come from Ilona's presentation, and I'll start with Oti here. Oti, if I can, direct first question to you, some of which came up from the chat as well. There are these gaps and decisions that we need to strengthen adolescent responsive PMTCT services, which is really key. And I wanted to, maybe you start us off by, first of all, those key programmatic gaps. What are, from your experience, the key programmatic gaps that you've seen that are hampering adolescent responsive PMTCT service?
Good afternoon and good evening to everyone. I'm greeting you from KwaZulu-Natal in South Africa. I would then want to quickly go to the answer. I need to have my points. The key programmatic gaps in the PhD services, and thank you for having me. One key gap is the integration of cultural and health programs, which will then talk into the primary prevention, because much as we're looking at adolescents and young mothers who are living with HIV, we would like to keep those that are negative. So we've got programs in our country and maybe in various countries that are already there for the young girls and young women. How do we then integrate those with our health programs so that we prevent the young mothers from getting? That is one. The second key gap has been talked to by Prof. Alona, is the prevention of unwanted pregnancies. We know that providing safer conception services will allow us to screen for intention of pregnancies, intention of having a child, and then providing quality fertility counseling for all the populations of childbearing age. But very much particularly, if we would offer those services in our public health facilities, we'll be able to tease off the adolescents to ask them to have a child anytime soon. So in case they say they want to, then they can go for planning. But most of the time, as it has been shown by the research that has been presented today, most of them, the pregnancies are unplanned. So we will then have an opportunity for those that said, no, I don't want to have a child, to then ask a secondary question to say, what is it that you're doing? How can we assist you? Then in that way, we will be able to then offer the method mix that will allow us to prevent unwanted pregnancies and unplanned pregnancies. The other key gap is the antenatal care services that we're providing are for the general population. We've got youth-friendly services in our facilities or maybe in our country, but in terms of having antenatal care included in the youth-friendly services, so that when an adolescent girl comes for antenatal care, the service is provided within the youth care-friendly service. The service is provided by a young healthcare worker, and not an old healthcare worker who will start opening and preaching to the adolescents. So we need that to close that gap, that when we're providing antenatal care services for those that have fallen pregnant, let that be within the youth-friendly care services. Lastly, the one key gap, we know the peer mentor program that it works. It's evidence-based, it's been proven. It provides psychosocial support. In the study that Elona has presented, it's showing that having peer mentors, it makes a huge difference in terms of supporting adolescents and young women living with HIV. Knowing it, having tried to implement it in South Africa since 2010, but we're not implementing it in a way that will be across all the facilities, that will give us the benefits and the impact that it has. Then what then are the key decisions? Maybe then I'm moving forward, Wale, to say what are the key decisions that then we need to improve services for young mothers living with HIV? We need to have policies in our countries that will allow us to recruit peer mentors by the government. Currently in South Africa, I will talk South Africa, we're relying on our partners to support us in terms of recruiting peer mentors because our policies don't allow us. Yet we know very much that the peer mentor programs work, that if we put adolescents, young mothers that are living with HIV on the forefront of their health care, we will achieve more impact. We have seen it works. We need a policy change to be able to recruit these peer mentors. Development partners, they need to include the peer mentor model on their plans. We know that it works. Let our partners then put that in their plan. We need global policy, technical assistance to assist us how to use the funds better. We know the epidemic that we faced with, and we know the response. We just need global policies, country policies, and technical assistance to do so. Technical support for adolescents-led program, we know they work. Let's get that from our partners. Let's implement programs that are led by adolescents themselves. And lastly, I want to talk then into the issues of stigma that Alona has talked into, the discrimination, we need parenting classes and support. We need to keep the girl child in school. We need to have skills-based education, empowerment, financial support. I think as Elona has talked into these issues, the legal part, we've got law in the country that adolescents can remain in school. But again, as you have seen, there's that 25% drop off. Out of the 25 drop off, only 70% returns back to school. What is it that we can do differently to close that gap? Working with the adolescents themselves, with the different departments, working together, education, DSD, and health. The sugar daddy, we've seen in the study, we still have got young adolescents that are impregnated by older people. In South Africa, the law says if someone has sex with someone who's less than 16 years, it's a criminal offense. But what are the actions that are being taken? It is about time that we take these actions for those that impregnate 16 years and then they go to jail. Thank you, Amayan. Yeah. That's where I can end. Thank you, colleagues.
Thank you so much. You know, such rich information. You know, what I like about what you've done, Oti, is, you know, I asked you a question about gaps, but you've looked at the gaps and you've now, you know, sort of related those gaps to decisions and solutions, and that's really key. Yes. You know, a lot of the time we get lost in, you know, this world of challenges and gaps, and we tend to forget that, you know, the key thing is actually, you know, programming for solutions and trying to, you know, turn those gaps into solutions. So I really appreciate that, Oti. One of the things that you mentioned, and I saw that this came through all of your responses, is on the need for, you know, adolescent and young peers to be able to be at the center of care. And I think that's really important. So I'll actually just go now to a couple of people who can speak to that on the panel. So first of all, I'll go to Peggy, and then I'll come to Immaculate. Something related, but just because in Oti's response, and rightly so, she sort of, you know, put that pitch in for young, for peers to be at the center of the response. So Peggy, to you first, if you don't mind. I know you've done, you know, a lot of great work with the Young Mentor Mother Program, implementing integrated youth-driven services for young mothers. And I wanted to see if you could, first of all, speak a bit about the Young Mentor Mother Program that that you know very well, and if you can bring out some of the elements that drive or that have driven the success of this program. Peggy. Can you hear us, Peggy?
Young Mentor Mother Program across 20 districts in Zimbabwe. The young mentor mothers, they are 18 to 24 years. They are living with HIV. They've been trained, they've been mentored as peer counselors, and they assist other young mothers who are living with HIV, who are either pregnant or breastfeeding. They also support their babies. Currently, we've got 133 young mentor mothers in Zimbabwe who are supporting just above 2,000 young mothers. Of these beneficiaries, 98% of them, they've got they are virally suppressed, while 97.6% of them, of the HIV-exposed infants, have had a negative result as a final outcome. So in terms of our successes is linked mainly to capacity of the young mentor mothers as they support their peers. They are capable, they are committed to support their peers. And besides that, our support is also linked to the integration that we have with the Ministry of Health and Child Care at all the structures, like the national structures, the provincial, the district structures. And let me be quick to say, this program is not a standalone program, but it is a program that is integrated into the national system, as young mentor mothers are known to be a key element in the prevention or the elimination of mother-to-child transmission. So by doing that, this support, as they get this support, it actually assists them in supporting other peers in terms of reducing viral load as they monitor those clients who are virally, who have a high viral load, and also prevent them from and also assist them in having early infant diagnosis testing. In terms of our challenges, yes, we can be having a few challenges that we are still working on. For example, we are still working on improving the early infant diagnosis sample collection. We are also still working on improving viral load sample collection. And we are also working on improving partner testing. Partners, like male partners being male, we know the health seeking behaviors that they are a little bit hesitant in seeking health services. So as a result, when we offer these services to them, like the HIV testing services, if they are negative, we then refer them for other medical services or any other biomedical prevention services. So in terms of our successes, this is what I can say for now.
Thank you so much. I think that is brilliant, and something that always resonates with me, Peggy, is programming for sustainability. So the fact that you mentioned, that what you're doing is as well integrated into national systems. Of course, there are challenges with that, but it allows what you're doing to be sustainable and to go the long term. I will come back to you, Peggy, with if you can just think about it, maybe later if there's time, I'll come back to you to, if you can highlight just a few key things that you would say are success factors. So if anyone wants to, have a model in Nigeria or in Sierra Leone, for instance, what are those key factors that you would want to highlight? But I can come back to that, Peggy. Let me go to Immaculate now, who is another another great champion that, that we know. Immaculate, knows, better than most on the need for adolescent responsive, youth responsive PMTSD services for young mothers. And Immaculate, if you could, first of all, talk about your experience. I know we've spoken a lot about OTZ Plus, the Young Mentor Mother Program. OTZ Plus was well documented. Both were well documented in the technical brief that I mentioned earlier. But if you can just give us share your experience, if you can, on OTZ Plus, and from that experience, if you can also sort of look at the sorts of interventions that OTZ Plus has in place to sort of narrow some of the gaps that have come out from what Oti and Peggy mentioned. Immaculate.
Thank you so much, Wole, and good morning, good afternoon, everyone. My name is Immaculate, and thank you for those questions, and thank you for the presenters who've gone before me. I think you highlight very critical challenges in adolescent mothers, and that affects how they take up services, how they remain in services, and how eventually we have good outcomes for them. So that is very critical. And talking about OTZ Plus, just to say, it's a program that is asset-based, and it looks at the adolescent as an asset, and it involves them in their care with a key goal of having an outcome that is favorable for both, in this case, both the adolescent themselves, their infant. And one other thing we've added in OTZ is reintegrating them to community, families, and going back to school, and those who are in college going back to college. So it's really a very critical package that looks at that. So there are a couple of elements that we've put in OTZ that help respond to the gaps. And one of them is knowledge, providing information for adolescents. And you will all agree with me that decisions that are right for themselves. So that is very critical. And this is more to do with both in the HIV treatment literacy package, as well as access to reproductive health services, as well as for HIV negative, providing information on how to prevent themselves from getting HIV infected in the next pregnancy or in future by taking up the currently available services and being able to negotiate their relationships. That is not about us, it's about me. And that is very critical when it comes to adolescents, because often at times you will hear an adolescent say, it's because somebody did this to me. That is why I did this. So being able to empower that adolescents to know that the decision I make is about me and it should be something that is good for me is very critical, both in their uptake services, both treatment and prevention. The second thing is, for those who are living with HIV, in addition to letting them know, the package of services, I think is empowering them to know that their choices, the choices they make, will they can choose to adhere, they can make a choice, and letting them know that, adherence is a choice you can make as an individual, and is a choice you can make that will have, result to good outcome. The other thing we put in place is connectedness. Connecting who are living the HIV with other adolescent young mothers. Everybody here agrees with me that being a young woman living with HIV, being pregnant or having a baby is a daunting task. So connecting them with other adolescents who are strong, who are also empowered, and who are saying, we can do this. We can have HIV-free babies. We can retain in care is very critical. And it plays a very critical role. And we have OTZ Plus mentors who are positions at clinics who talk to these adolescents. Some of them are successful PMTCT mothers, and they are able to connect with their peers, probably better than how a healthcare worker can connect. I mean, it's easy for an healthcare worker to read out the family planning methods, but it is much, much easier for a young adolescent to tell the other adolescent that, look, this is what I told my boyfriend. This is what I told my spouse. This is how I stood against gender-based violence in my marriage. So it is very critical for us to know that when we empower adolescents through other adolescents, it is very powerful, and it's a powerful tool that we cannot ignore. The other thing we put in OTZ is positive outlook. Giving up is not unusual for young mothers. Feeling like the world has come down crumbling, my youth has been taken away, and being able to set a space where they can understand that it's not finished. I can go back to school. I can go back to college. I can become that teacher I want to be. It's very critical in our programming. And then essentially just letting them know that they are the part of the solution that we want to see, engaging their caregivers, because one of the critical things that young mothers face and is often unspoken is rejection from the family, rejection from school, rejection from the community. So how do we bring these people to know that if there's a time that an adolescent needs support is when they are a young mother and they're living with HIV. And that is very critical. And when we bring the caregivers on board, they are able to provide the much needed support. Caregivers also give up on adolescents. So it's very critical to bring this messaging that it's not over. It is very important for them to really be part of the solution that we want to see, and empowering adolescents really to take charge of their health and ensure that they can have HIV-free babies is very, very critical for us in OTZ programming. We've seen very good outcomes, 100% infants with no HIV infection among AGYW, quite compelling, high retention rates among AGYW, high viral suppression among this population, and it's very possible to have this very delicate population really have good outcomes, and that is what we call responsiveness in programming. Thank you.
Wow, I think that is just that's just brilliant. What you've done is you have so very well just put in place. You've painted a really good picture of the interlinked areas that are needed to sort of advance the models. Like Peggy mentioned, like you've mentioned, there are things, the critical things that we need to always consider when programming for young mothers. And I think it's really key, your take as well on the support networks, the families, the society, the communities, and how those play a really important role in building successful models like yours. So thanks for that. Just as I move on, hearing from Peggy, from Immaculate, a lot of what has been mentioned, even from Oti. So Oti mentioned something that had to do with constraints in financing and funding. You need investments, to be able to do the great work that is happening in countries to achieve the desired outcomes. I'm just going to go to Augustina to just give us a bit of her thoughts about investing, focused investments. Augustina, if you can just speak a bit to areas of investments that are needed to promote the sort of quality services for young mothers, as enumerated very well by Oti, by Peggy, and Immaculate, and probably just look a bit about the work that you were doing at the CDC as well to be able to support these sort of investments. Augustina?
Thank you so much. Thanks for having me on. Thank you everyone so far who's shared all this wonderful information and insight and experience. I think there are a number of areas where investments can be made that can really improve the services for young mothers. One of these areas to think about is investing in the training of healthcare workers and other clinical staff who are interacting with the young mothers, so that they have the skills to provide age-appropriate and gender-sensitive care. It's really important to have a stigma-free, safe, non-judgmental environment for these young mothers. And that starts with the staff who are empathetic to their needs and the needs of their families. And hopefully we'll create an environment where young mothers are more likely to stay engaged within their care throughout their pregnancy and during the breastfeeding period. one of the ways that CDC is working towards this is that we work with organizations and healthcare providers to provide training on how to safely screen for gender-based violence and how to provide care once a woman has been identified who is experiencing gender-based violence, making sure that she is being linked to the right services and is able to sort of safely navigate those experiences. I think another area to think about is investing in health information strengthening for PMTCT entry points such as antenatal care. There are a lot of efforts right now in countries to strengthen the health information systems, but often the PMTCT entry points are sort of left behind. There's issues with internet connectivity, equipment availability, and even when there are electronic medical records available, they don't often have a way to capture PMTCT information. So this is something that CDC is helping to invest in the development of a PMTCT module that is for the Open MRS, electronic medical record system, to hopefully be able to capture better data so that we can identify where the gaps are and where to best put forth our effort to address the highest needs for young mothers. Another area which I think has definitely been touched upon is investing in the development and implementation of service delivery models that are tailored to the needs of young mothers. So CDC works with ministries of health. They work with other organizations to develop pilots and implement them and evaluate them, and then to help scale up those programs that we know are effective for meeting the needs of young mothers. So one of the examples that was already brought up is the OTZ. Another example is group antenatal care, which can be scaled up on a national level. I think the last area is working on investing in relationship building between clinical and community partners. I think this is really critical because, as many have touched upon, there's sort of all of these needs that young mothers have and trying to make sure that they get all of these services, that they're easily accessible. So CDC works with community-based programs that are supported by PEPFAR, but also by other funders to make sure that young mothers are receiving both comprehensive treatment and prevention services. So young mothers who test negative can be linked to prevention services such as PrEP, DREAMS, and Orphans and Vulnerable Children programming. And then those young mothers who test positive can be linked to OVC services so they can receive case management, where they ensure that they receive optimal ART regimens, that they are getting regular viral load testing, ensuring that their infants are receiving prophylaxis, ensuring that their infants are being tested at regular periods throughout the breastfeeding period, really to ensure that both the mom and the infant can remain healthy throughout their care and that the baby remains HIV free. Thank you.
Thank you very much, Augustina. That's a really good way of framing some of those investments, and just keeping in mind, especially the role of health workers. Sometimes we don't engage as much, the health workers, and we know that probably over 90%. There was a stat actually on that said, over 90% of HIV services are actually provided through facilities. So that's about health workers. It's about investing in training and mentoring for health workers. So thanks for that. I think we have a good way to sort of round up and end this panel in the right way. What has been common to everything that you've so brilliantly said, Otie, Augustina, Peggy, and Immaculate, has been the central role of young people themselves. Yeah, they have to be, front and center. We must, make sure that the needs, the considerations come out clearly in terms of how they want and need services. So I'm just going to, pass on to Cindy, who's worked, quite tirelessly with us over the last year at the WHO Adolescent Service Delivery Working Group, in making sure that the work that we do, we completely do not miss out that critical element of young people and what they need. So my final question to finish will be to Cindy. You know, for you, you know, we keep speaking about you know, this meaningful involvement, meaningful engagement, and I wanted to get your sense as to, you know, in practice, are you really seeing this engagement? What more can we do globally, but also in countries, to enhance and plug the gaps of the lack of engagement of young people? So if I can just get that from you, Cindy. Over to you, Cindy.
Thank you very much, Wole. So, as a young woman myself, I've had the privilege of engaging in youth programming on 2 levels. Of course, at the very first period of time, I was basically a beneficiary, as many people would call us. And then in my, of course, later on, I've been involved as an active leader and even in program implementation capacities. And as a youth leader myself, I always ask myself, and I'm always trying to figure out, how exactly can we also involve young people in a more meaningful way, especially in decision making and in all other processes that affect their lives. So for me, I would first define meaningful youth engagement as the intentional, appropriate, ethical involvement of young people in all programs and decision making processes that affect their lives. So for me, meaningful youth engagement is meant to empower young people. If they do not have skills, it is meant to empower them to perform their duties and gain those skills that they need to perform their duties. If they do have the skills, then already we have to tap onto their skills of young and enable them to make decisions about themselves free from influence of any other kind. So young people should be seen as valuable stakeholders in service delivery, and feedback that they give back on the satisfaction of services should be taken up as invaluable in shaping new service delivery models, especially in our facilities. In the past, we have seen that a lot of the time, we as young people have been looked at as beneficiaries, as statistics, and our engagement was previously in a very tokenized manner. However, in recent times, we have seen that more partners, more stakeholders are seeing value in our positions, are seeing value in our skills, and they are looking at us as equal stakeholders, equal partners, and equal implementers in our programming. So just to some few pointers that may help improve meaningful youth engagement. One is we have to intentionally involve young people from the start of the programs and until the end, of course. So when we are creating programs that target adolescents and young people, we should purpose to involve them in stages of implementation. They have to know as young people that this is the way we are going to be involved. They have to understand their specific roles. They have to understand their engagement processes, how they are important in achieving the outcomes of the program. This will not only enable the young people to feel involved, but even for the decision makers to know how exactly can we support these young people to achieve the programmatic objectives that we have set for this program. The greatest impact will actually be seen when there is actual transformation, but when the young people can actually connect their transformation to they can connect themselves to the transformation that is happening. And in this way, we can be able to achieve the programmatic goals and even make the achievements very sustainable. Number 2 is to ensure that adolescents, the knowledge and the value that adolescents bring into a program can be acknowledged, because it is we do bring a lot of wealth and knowledge into programming, especially for ourselves. So if you look at all programs that we have implemented as Y+, you will see that the young people like to engage when their contributions and efforts are recognized and valued. It gives them sort of motivation to keep advocating for the various causes and gives them visibility to the other stakeholders that are involved. So just to ensure that you have meaningfully engaged, there should be provision of a safe space and youth-friendly tools where they can expressively share their thoughts, and you can be able to collect feedback and identify the programmatic gaps and solutions in that specific program. And in return, we should be flexible enough to adapt to their needs and address their issues as they come in a very timely manner. Lastly, is on the meaningful youth engagement, is also about youth-adult partnerships. We often forget that at the end of the day, we might need someone to help us, to guide us, to give us those skills. So adults should purpose to find resources and opportunities that support adolescents and young people to gain these skills, these technical capabilities, because most of the times when you do a lot of things, you will hear that young people do not have the technical capacities to perform this. So they should provide us with the technical capacities, while at the same time, we as young people should be willing to sit down and learn from our, of course, the adult population. So of course, when young people now are engaged, they are more equipped with the right skills. It is very easy for them to rely on their own capabilities when addressing these issues in their lives, in making decisions that involve young people, in ensuring that programmatic goals are achieved in a very meaningful way for themselves and even for other young people. So definitely youth-adult partnerships provide a perfect way to ensure that young people work in an enabling environment and they're able to even practice their skills and what they learn on the ground. So just as a takeaway, this is my own addition, youth leaders should also purpose to engage their peers as equal partners so that right from the start, we are including the adolescents and young people in a way that we would want ourselves to be engaged in, because you don't want the same kind of thing to happen, because soon enough you're going to transform adults. And then we will be the youth adult partners now, and our older young people, the young people then will be asking, we don't want them to think the same thing, that, oh, we want to be engaged meaningfully. We want to ensure that when we are now mentoring the younger people, the younger people than us, that we are giving them the exact expertise that we need, that their experience is different from our own. Yeah, thank you very much.
Yeah, I couldn't, I can listen to Cindy all day, and you've just said it exactly right. We need to engage young people, right from the start and across the cascade, not for some and then leave out others. Is actually, we need consistent quality engagement is what is needed. On that note, I'm going to just first of all, thank all the panelists. You've done really amazing to bring out all of these points in a succinct, easily digestible way. But also to thank, all of you as well, because I know you work with, other people who have supported in one way or the other. A lot of the work that is happening in the region, for instance, with UNICEF. I know, the government of Sweden is funding a lot of the work as part of, that joint UN Together for SRHR programs, with Augustina, Cindy, Oti, providing, really great support. And of course, Peggy and, Jandiri, the sort of models that you all have become is just an inspiration to all of us as we move this very important work forward. So I'm going to thank you so much for that as I hand over to Maxi. Maxi, what do you think about the panel discussion?
Well, that was such a rich discussion, really. It was really engaging. I could hear examples that we can learn from. And of course, the bonus, Cindy, actually representing, young mothers, young people with their diversity, speaking about young people and what we need to consider when we want to, have an informative programming in terms of young people. So really, thank you so much, everyone, for listening, for engaging, for those wonderful questions that are coming in. And I know Wolo's got a plan for us to actually go into those questions, right? Those 4 questions that you would like us to go through. Yeah.
Yes. So you're right. We have a poll, like we do on the ECHO platform. We try to just have a bit of poll, a bit of fun, really, just to see how we can, see some questions, answer those questions, and sort of just, maybe educate ourselves. So what we have is a 5 poll actually on adolescent sexual reproductive health, which is relevant to the topic of discussion today. So we've gotten these questions from the WHO Adolescent Sexual Reproductive Health Department, who have 5 questions that we would just like everyone to engage in, and we will give you the answers just as we go ahead. So can I ask Team ECHO to project the first question? And we'll just give just a few seconds for people to respond, and we'll show the answer and go on from there. So this is the first question. You should have it on your screen. It is. So the right age to begin sexual health education is, what do you think? Is it around 5 years, 8 years, 12 years, 18 years, or none of the above?
Now I see. So me is moderator. I can't answer this.
All right. So maybe if we can get the responses, if you have them.
Don't worry.
So the panelists and the host cannot vote, is what I understand. So Team ECHO, do you have responses yet? Well, if you're showing anything, I can't see anything. ECHO.
We want to see who's right. Ooh.
Oh, right.
Wow.
Look at that. Look at that, Maxi. So we have some 5, some 8. So, yeah, interesting. And actually, Maxi, the correct answer might also surprise me and you and everyone. Is actually sort of none of the above. Because so according to the International Technical on sexuality education, there's actually no magic date to start this sort of education. What is important is for them to be developmentally appropriate. So even preschool children can start learning about their bodies, what it's called. What is important is not really it's more about the making it developmentally appropriate. So that was the first one. Let's go to the second poll. Right. So contraceptive methods such as pills, implants, IUCDs, they have a negative effect on the health of adolescent girls. Right, we have a response. Is it coming, TeleECHO?
It's like when I'm waiting for my final exams, right? We are anxious.
waiting for the answers to come. They haven't shown yet. Oh, yes. So it is here. The answers are here. Yeah, so of course it is false. So age does not constitute a medical reason for refusing or providing contraception. In other words, there is no medical reason for withholding, of course, except there are contraindications and so on, for withholding the provision of contraceptive methods to adolescents. Super. So let's go to poll 3. Well done, guys. That was, I think most people got that right. Poll 3, if you can. So this one is about child marriage, defined as one in which one or both persons are below the age of 18. This is a globally defined term. The question is gone from my screen. TeleECHO, I think the question is gone. Yeah, that's it. So, how prevalent is it? Who the, is it 1 it is globally, 1 in 5 girls globally, 1 in 2 girls globally? That's it's a tricky one, I think. I remember, yeah, Max, when I answered this one, I was actually I got it wrong. Because I'm telling you, I was not chuffed at all. I got it wrong.
Yet I want to copy from you. I was like, can you show me your answer so that I can copy,
Don't copy me on this one.
We'll
So
get the right one from this guy.
Yeah, we'll get the right one. Right. So if you have the response, let's have it. Right. So we have 25%. So the most, maybe about 26% say 1 in 25 girls globally. You have 25% each saying it's 1 in 50 and 1 in 10. 14% 1 in 5, and 10% 1 in 2. So it's a one. Anyways, the correct answer is 1 in 5. So it's really prevalent. Globally, it's estimated that 1 in 5 girls below the age of 18 are married, or in just give me a second here. I'm not sure why this is not sure. Yeah, so 1 in 5 girls below the age of 18 are married or in some form of union. In some countries, however, it's the proportion is actually higher than that. So it could be 1 in 3 in some countries, but globally it's 1 in 5. So that's important information to have as well in terms of thinking about the prevalence of child marriage and all of the things that come along with that. Next poll, please. We're going on quite well. Right, so poll 4 of 5. Girls under 18 are up to 5 times more likely to die in childbirth than women in their 20s. question is a sort of similar question about the differences that we have. So what is this? Is this true, false, or probably false? That girls under 18 are up to 5 times more likely to die in childbirth than women in their 20s. The poll is, I can't find it again. Maybe it's just my screen, but I'm hoping you're able to respond.
It magically disappeared. Yeah.
All right, so we give just a few moments for people to respond and then bring up the answer. All right, let's go with the response. TeleECHO. I think the response is about right. So the majority say true, and then say false or probably false. So the answer actually is that is actually true. You know, up to between 2 to 5 times, they're up to between 2 to 5 times more likely to die in childbirth than women in their 20s, for instance. So that's really, you know, it's stark information. It just tells us the starkness of what we're dealing with in terms of you know, not just HIV but other you know, subsets. And that's why we speak about one type of service, because all those services, sexual and reproductive health, social protection, they all are sort of interwoven for protection and support for young mothers. Finally, can we go to the last poll, number 5? Poll 5. TeleECHO. Super. It's gone again. Let's have the last one. So which of the following is the leading cause of death among 15 to 19-year-old girls globally? So is it direct diseases, pregnancy and childbirth, complications, road injury, or self-harm?
That's quite a tricky one.
Yes. All right, let's go, TeleECHO, with the response. Oh yeah, so 89%, maybe not as tricky, Maxi. So that is correct. So pregnancy and childbirth complications, alongside tuberculosis as well, are now the 2 leading causes of death among 10 to 19-year-old girls globally. So that's where the polls, you know, stop us. Thank you so much. As I hand over, what's next, Maxi?
I think that's you, Wale, and then you just wrap it up. Then you hand over to L'Oreal, my exciting L'Oreal to close off.
Yeah, but do you have last words before I turn it over to Larry?
I love the last words. Thank you so much. This has been a really rich and interesting conversation, and it's really great to see all opinions, which means really we are all thinking about young mothers. We are all thinking different ways to really tackle and, you know, meet the needs of young mothers in their diversity. Please go to the online for both WHO as well as UNICEF to get the technical brief. Remember those key strategies that we talked about, which are really important. And as much as about that advocacy, let's continue to drive it, and we can make it as a collective, really. To the wonderful young mothers that gave, you know, their personal lived stories, you are my fans. I am your big fan. I'm your big fan. Thank you so much. Yeah, thank you everyone.
Thank you so much. I really appreciate your time as well, Maxi. Just to say that we have, the topics lined up for 2022. Really exciting topics, as you see on the screen. We've done today's. We have management of HIV/TB co-infection on the 5th of April. Peer-driven models. I'm really looking forward to that one on the 7th of June. In August, we have quite a clinical topic: HIV drug resistance and sequencing. All of those discussions that go around that. The 4th of October, we have mental health. Oh, that's a big one. And HIV integration. And then finally, as we round up the year, we have implementation of DSD models on the 6th of December. It is now my pleasure as well to just hand over to Laurie. Laurie Goulet from UNICEF SRO has provided a lot of support and supervision, actually, to the work that who's on the call and all of us have done. So just to say again, thanks to for that support and supervision. And I hand you over to Laurie.
Thanks so much, Wole. I really appreciate it. Let me start by quoting my dear friend Maxi. Wow, wow, wow. Right, Maxi? It is such an honor to make a few closing remarks after this really powerful session. While it is true that adolescent and young mothers living with significant risks and challenges, these risks and challenges do not need to be insurmountable. As has been reinforced over and over again today, success requires a human rights-based approach with government leadership and commitment, full engagement of adolescent and young mothers, allocation of adequate resources, something we must always remember to say, tailored programming, and collaboration among multiple sectors. We at UNICEF are so delighted to have been part of this process and the development of this technical brief. We have partnered with government and civil society on the implementation of differentiated service delivery for adolescent and young mothers for many years now. And we are so excited to see that this programming and advocacy is increasing with this vibrant population. It is important that we use our learning, which is so well documented in the brief, to take this work to scale, ensuring that is institutionalized the method of for all adolescent and young mothers. Take it to your technical working groups, refer to it as you plan and review national and local interventions, share it with colleagues in health, education, social welfare, and other sectors. Ultimately, we really hope to see those 7 strategic actions outlined so clearly become fully embedded in national policy and implementation across sectors. We want young mothers to realize their vision of the best life possible, as was so eloquently shared by Alona in her presentation. So let me close today with a heap of gratitude, first and foremost to all of the country governments and partners doing the work and who shared their programs and learning. Also to our funding partners who have presented today and who we have mentioned, including the government of Sweden, who we work very closely with, the joint UN team. Sincere thanks to you, Wole, and of course to Alice Armstrong at UNICEF in Eastern and Southern Africa, who co-led the development of this brief. We also express our appreciation to CKABA and the WHO Adolescent Service Delivery Group. They really gave expert review and contributions in shaping this brief, and to Judith Sherman, who was our lead writer. To our speakers, facilitator, and panelists, thank you for your active engagement and wisdom shared. It was truly an important discussion that was really grounded in evidence and diverse experience. And finally, to you, the audience, thank you so much for attending, for the great questions, for your interest and dedication. We all hope that you feel inspired, and we look forward to continued collaboration. Thanks a lot.
Thank you. Bye, everyone.
Thank you. Bye.
Bye, everyone.
Bye, everyone.
Bye, y'all.